Hello, everyone. So we meet again at our second session. I'm Dina Kamalasari from Faculty of Medicine, Universitas Sumatera Utara. This is our second meeting. And today we will discuss about how to calculate energy requirement in cancer patient. Okay, we will start it now. I will share screen, okay? Yes, this one. Just a moment. Now everyone can see this? Yes. Okay, we will start it. Okay, from the previous our meeting, we are discussing about what's the appropriate nutrition for the cancer patient. So today we will discuss how to calculate the appropriate nutrition for cancer patient. So I think this is important, and this topic is trying to explain how to make a calculation, a very easy calculation to the cancer patient. I will slideshow with a moment. Yes, okay. Okay, this one. Okay, we'll start it now. Yes, for learning outcomes in this meeting, in the lifelong learning courses, we will create nutrition management for a variety of types of cancer. But in this topic, we will talk about how to calculate in cancer patient for all. Okay, from the reference, you can read the Krause's Food and the Nutrition Care Process or any other books such as Nutrition and Cancer Prevention, Nutritional Oncology, or Nutrition and Cancer Prevention, New Insight into the Role of Phytochemical. You can read all of that. But also, you can have a reference from other journal, previous article about nutrition and oncology that will add more information about this topic. Okay, now we start how to do the calculating total energy requirement. The body's metabolic state is stable, so we need to calculate total energy requirement which is equal to total energy expenditure. We can call it TEE. The stands for total energy expenditure. So when we calculate total energy requirement, we need three factors here, which are basal energy expenditure, diet-induced thermogenesis or thermic effect of food, and the last is physical activity. But when we want to calculate a cancer patient or somebody with the illness, so we need to add more energy because a person or a patient with the cancer or the illness, they have some catabolic state, higher catabolic state than the normal person. So we need to add stress factor in here. We call it the SF, stands for stress factor. So the energy requirement will be increased in the stressful situation due to surgery or illness. Now, we see in the components in the TEE calculation, there are basal metabolic rate or basal energy expenditure, resting metabolic expenditure, resting energy expenditure, and the second is, this is all the same term actually, and then the second, diet-induced thermogenesis, and the third, activity energy expenditure, AEE, and the last is stress factor. We will discuss about what is basal metabolic rate or BMR. So energy requirement used for physiological function of the body. When we sleep or when we do not do anything in the stable state of our body, we still need calorie energy to metabolism function of the body, such as heart, lungs, body biochemistry, basal metabolism, and electrochemical gradient. It all needs energy. Usually, we use a direct calorimeter, and to measure it, we use it on a basal level early in the morning when the patient is still sleeping. But a problem in here to use the direct calorimeter, it is difficult to do in the clinic. So we will use this calculation. Okay. Resting metabolic expenditure atau RME. We can measure it using an indirect calorimeter, and then we measure the consumption of oxygen atau VO2 at the rest position. And the patient is in a fasting state around 12 hours and at least 1.5 hours of rest. There's ambient temperature and stable oxygen requirement, but there is some limitation in using indirect calorimeter. It overestimate about 10 to 20% greater than BMR. And this resting energy expenditure, it means that energy expended in the activities necessary to sustain normal body function and homeostasis. REE can be determined by measuring oxygen consumption in resting and stable states. Okay, we move to diet-induced thermogenesis. The diet-induced thermogenesis, or DIT, is the amount of energy used for the digestion of food, oral or enteral. And the values vary depending on the type of food given and the metabolic state of the patient. And we can predict that oral estimate around 10% of RMI. So we can add 10% from the basal metabolic rate. So it can give some extra energy for that. We move to activity energy expenditure. So AEE. The value varies depending on the type of patient physical activity per day. So we can add 20% when movement is limited in bed, or 30% for outpatient. 30% for outpatient from the basal metabolic rate. Okay. Or we can, for easiest way, we can multiply it 1.2 or multiply it 1.3. And then the last point is stress factor. We know that metabolic changes due to stress cause the patient energy output to increase. Will be increase the energy output. So could be patient with complication can reach 100%, such as cancer patient or burn. Now, this is the stress factor determined by type of trauma, injury, and infection. So from the up here, you can see that there is, twice energy than in the basal metabolic rate. So we multiply it with 2.0. And this is the other stress factor. You can see that most of them mention that cancer and burn is the most higher stress factor. Now we can move to total energy expenditure. So in total energy expenditure, according to STAM, the reference that there is to determine the energy needs of healthy individual based on body weight and activity. So we see the activity around 20, 25 energy we can add. It called light for every weight, and then moderate about 30, and the heavy is 35. We can multiply it around this percentage. Okay, and then normal weight and also in underweight. We can see this activity in kilocalorie per kilogram. And then this is the total energy expenditure according to Sarah. The dimension we using the estimate resting metabolic energy with Harris-Benedict formula. So we use here, there is a total energy expenditure equal to resting metabolic expenditure multiply to activity factor and multiply to stress factor. We can add here also for the thermogenesis effect of food or dietary induced thermogenesis about 10%. So before we move to this calculation, we will estimate the resting metabolic expenditure from this equation. This is for men and this is for women. And this is calorie per day. This is also kilocalorie per day for women. So there is a difference between men and women. So this is very easy when we we can use this one. 66 plus 13.7 multiplied to body weight plus 5 multiplied to 8 in centimeters and minus 6.8 multiplied to age. It's also the same with women. 655 plus 9.6 multiplied to body weight plus 1.8 multiplied to height minus 4.7 multiplied to age. Age in year, body height in centimeters, and body weight in kilogram. So this is according the total energy expenditure. We add for resting metabolic expenditure plus dietary induced thermogenesis plus physical activity plus stress factor. And we can have it kilocalorie per day. Several studies have stated that there are many obstacles in determining patient needs, including body weight is affected by hydration. Patients who are too thin or too fat often lead to excess or underkneading, and stress factors are not always easy to determine and often misinterpret the needs. And for that, it needs to be assessed individually according to the clinical, laboratory, and nutritional status of the patient. So we talk about energy sources, and after we do the calculation, we have to divide it on how the composition of the calculation, the total energy expenditure. So we will divide it into some percentage that which are carbohydrate about 60 to 65%, protein 10 to 15%, and fat 20 to 25%. And energy resources are obtained from all three sources, but protein should not be used as an energy source. This is for the example, how we can see this. And don't forget, carbohydrate, we have to divide it into, the equation is to 4, and fat is 9, protein 4, alcohol is 7. How to metabolize energy, kilocalorie per gram. We know that most of them is lost in, we will digest it, and then the energy we eat, use, and all the nutrient will be metabolized to with our body, and then we can use it as the energy. For protein requirement. So the requirement of the protein is important to note that age children in their infancy need greater amounts of protein than adults. Weight and height protein determination is usually based on ideal body weight. The degree of stress, patients with major surgery and sepsis require more protein, and type of diseases, impaired liver or kidney function, and also biological value of food protein, especially essential amino acid content. And how about vitamin needs? The patient with protein malnutrition, especially in cancer patients, often have vitamin deficiency. especially in clinical or laboratory. In some circumstances, they need for vitamin increases up to 10 to 20 times above the RDA, and in circumstances moderate to severe metabolic stress including cancer patient. Also, starvation, alcohol drinker, administration of drugs, deficiency is more common with parenteral and nutrition than enteral nutrition. So, we have to understand about this condition, but be careful also to use the vitamin. Very, very be careful. It is better that we consume in the food sources. It's much better than supplementation. But if you want to give supplementation, vitamin supplementation, you can predict, do not give so, you know, give the status nutrition of the patient. You give higher dosage is more risk than the lower doses, but you have to really understand about the dose. Okay, how about mineral needs? So there are some mineral needs that very essential element, and probably the need increases to 5 times the RDA requirement. And we all see that there is disease injury. So we can see that there is so many factors here, total energy expenditure, and there's metabolic state, physical activity, and all this thermic effect, food or medicine and hormone. This is all will affect how we can count the energy requirement. Now, how about the artificial nutrition? We all know that enteral and parenteral nutrition is selected depending on type of cancer, its extent, complication, treatment and prognosis, and on the patient's status, need, and duration of nutritional support. If we give the patient enteral nutrition by tube, it's indicated its intake oral is lower than 60% of requirement despite nutritional intervention per oral, and gastrointestinal function is preserved. Of course, gut feeding is, we have to know that we have to give to feed the gut also. Now, if you want to do the parenteral nutrition, it's indicated when it is not possible to use the gastrointestinal tract, oral feeding and or enteral nutrition does not suffice, and there are expectation of improvement in the patient's quality of life and functionality with the patient expressed desire. So we have to know that how to use this artificial nutrition. And the summary, energy requirement used for his physiological function of the body of the cancer patient, and need more energy for the stress factor, and need selected vitamin and mineral in some cases. Okay, thank you everyone from right now, and I will ask you, we have assignment. If you can you can read 2 or 3 articles about nutrition and oncology. It will be help us to understand our next topic. Thank you very much. Bye-bye. I will stop share. We will meet again. Okay, bye-bye.